Okay, good. So deep venous thrombosis and pulmonary embolism. So why do we put them together? Are they the same disease? No. They are related, but not exactly. For example, pulmonary embolism can be fat embolism, like air embolism or cell embolism. So deep venous thrombosis is not the only etiology of pulmonary embolism, but it's the most common. So when people have like pulmonary embolism, usually they think of deep venous thrombosis as a cause. And in internal medicine, like I think they put it together. So you should focus more on deep venous thrombosis etiology of pulmonary embolism. But know that there is also other etiologies, okay? So we're gonna do them together. As always, in the first part of my preparation for the state exam, I talk a bit and give a bit of tips about the exam. If you look at your AMBOS books, basically every theory book, you're gonna find this structure. Like they start with some theory, then like definition and stuff. Then they go to like etiology, causes, risk factors, pathophys. So they have some uh, explanation of how the disease happens, let's say, or what is the risk factors. So this is basically what, as a doctor, you will ask in the patient history. So in the patient history, you're going to ask these things. So when you go to AMBOS or any book, you're going to find definition first, then you're going to find etiology, causes, risk factor, pathophys, then signs and symptoms. Do you know what is the difference between signs and symptoms? You should know by now. If you don't know, does anyone know signs and symptoms, the difference?
Symptoms is what the patient describes. Signs is what you can see yourself, right?
Okay, good. Yes, correct. But remember that symptoms they can be simulated, so they don't have it, but they lie, so they can get the paper or something like days of school or whatever, days of job. But the signs they cannot lie, and also the symptoms they can hide it. So someone should have maybe pain, and he's trying to hide it, and he says, "No, I don't have pain. I want to go holidays or whatever. Please let me get out of the hospital." But if you look very closely, you can see that he's walking differently. He has pain. He actually has some guarding maneuvers. So base everything on your signs, but ask for symptoms. But just know in real life symptoms they're not that reliable. So science is what is most important, and this is the reason why our professors they have all these named signs, and they give so much emphasis on science, because symptoms can be faked or not or hidden, while science it's there. And also you can do the specific maneuvers. So there's different maneuvers for neurology, different maneuvers for orthopedics, and different maneuvers for internal. Yeah, and then you have diagnosis, like what is the bloods, imaging, special tests, uh, and then finally they finish with the treatment. So this is how every theory book, AMBOS, present the diseases. There's also differential diagnosis. I forgot to put it there. Yeah, and now in physiology, and basically they change the curriculum. They try to follow the international standard, which they use in the United Kingdom, which is the SBAR. So SBAR is like situation background assessment and recommendation. So SBAR is a mnemonic of basically a structure how to communicate with other doctors, how to present your case. And if you look at it, it follows a similar structure. So history, signs, symptoms, diagnosis, and finally treatment. So if you study this way and you explain your exam like this, like AMBOS, you are basically prepared for the clinical one, the SBAR. The only difference is that you don't have these etiology, causes, risk factors, pathophys. You don't have it in clinical practice because you don't care for it. But now we're doing a theoretical exam, so we do care, so we have to add it there. While working in the hospital, what is more important is like, what is my question? What is the problem? Like, why did he come here? So we don't care for theory, we care for some other things. So just know SBAR for people who never saw it before. It's a way to communicate, and it kind of follows the same structure as theory. But for our exam, we need to know this part, pathophys, causes, and risk factors. Okay, so how to study internal medicine? In real life, in the clinics, we have the ABCD, so airway, breathing, circulation, disability, and everything else. This is the mnemonic that you should follow your, let's say, diagnosis and stabilization. Um, when a patient comes in, what you want to do is stabilize them. Okay, so if they come in and they are not stabilized, you need to stabilize them. This will give you time for diagnosis, because diagnosis can take maybe days, to get a diagnosis. So if you have ever done ATLS, Advanced Trauma Life Support, they stress this procedure, like this, let's say, progress very, very strongly. So we can say diagnose and stabilize, but you don't actually give the diagnosis, you just evaluate and stabilize. So in real life, you try to evaluate. So you start with airway, you evaluate it. If it's okay, you move on to breathing. If it's not okay, then you do something for it. So stabilize it. This is called temporary treatment. And I'm giving an example here. For example, airway. Okay, we start with airway. We see if the patient speaks for patent airway. So we're evaluating, like not diagnosing, but evaluating the airway. If there's some pathology, then we start to, I don't know, check them out, remove foreign object or whatever, intubate. So this is our stabilization step. It's not the final treatment, the permanent treatment, but it's going to give us more time for diagnosis. Remember that if at any point, like you go A, B, C, you go down these steps, if at any point something before changes, you have to go back to it and like start from it again, continue, like start from the beginning. So if you're at C, so you fix the airway, you fix breathing, now you're in circulation, and then you notice that A changed. For example, the intubation, it went out, it came out, the intubation. So what you need to do is go back to A and start from the beginning. So fix the intubation, but then don't go back from airway to circulation. Again, do breathing. So it's basically A, B, A, B, C, A, B, C, D. So it goes like this, okay? Like always be alert to what is happening. Yeah, so you do A, B, C, there's some change, do A, B, C, D. Go back and start from the beginning, okay? This is real life. So we call this temporary treatment, and this is permanent treatment. And the temporary treatment is to buy time for diagnosis, okay? This is what real life, or if they give you a clinical scenario, or if you go to England, you should follow this pattern of thinking, okay? Now for history taking, in England, they have this sample history. It's like signs, symptoms, allergies, medications, past medical history, last oral intake or menstrual cycle, and then events leading up to this injury and presentation. The point of this is that it's also used in ATLS, so you have to memorize this for your surgery state exam. It's that it's fast history, you know, to get an idea of what might be the etiology. So like guide us, like where should we be looking, but also be prepared for surgery or some pharmacotherapy like allergies, medications. When did they eat? Are they pregnant? Can they, if they have acute abdomen, can they go to surgery? Can we operate on them? So yeah, like allergies, medications, past medical history, try to find the cause, prepare for pharmacotherapy, yeah, and sign the symptoms, like find the etiology, and then the last oral intake and last menstrual cycle is to be ready for surgery if there is some acute. So this is what you do in the beginning. So at the moment of stabilization, if I go back, at the moment of stabilization, it's good to have a sample history, like a small sample of the history, like just to know what's going on. So basically, while doing the stabilization part, you can ask someone else who was there, or the ambulance guy, or who is there, eyewitness, take a bit of sample history if the patient cannot say himself. If he can say himself, then take the history from him while stabilizing, okay? So this is like the very first steps. So then after, when you have time, after the stabilization, or for example, when it's an outpatient visit, it's a planned visit, and you have so much time, you can go on and do the complete history, or when the patient is in the ward. So sample is what we use in the beginning of like stabilization and get all the information before the patient collapses or loses consciousness. So get this is the most important information. They will not help with, let's say, diagnosis, actually diagnosing it, but they will help with preparing for surgery or some procedure that might happen, allergies, so we don't kill the patient with some allergy. So it's basically trying to make us safe and also guide us about the next steps. And after, when you have time, do the complete history. There's also something called focus history. It's also fast and short, but it's specialized. For example, remember our pediatrics clinic, we had this heads and craft. It's like specific history questions. So there's also like pain history, which is here. So these are specialized questions that you need to ask for the specific thing, okay? So when you have a patient, you have no idea what's going on, get the sample, make A, B, C, D, stabilize, and then do the complete history and do the complete diagnosis and permanent treatment. That's how the doctor should work in the hospital. So now we're doing a state exam, so it's theory. The problem with state exam is that in differential diagnosis, they might give you a clinical scenario. So they will tell you, hello, I'm a patient, I have this thing. So what are you going to do? So this is where you should show that you know how to make history, sample history, make ABCD, stabilize. So all of these things can be asked if you go into a clinical scenario. Linhart does clinical scenario, Professor Linhart. I don't know other professors what they're doing, but be prepared for it. And yeah, like you know everything, you studied everything, you know it very well. You would be prepared for it. Now, history of pain. There is this Socrates mnemonic that they use in England and NHS and whatever. So it's like side onset character radiation associations. You can see it here. But I like to use this one. It was given to us in first faculty in the Czech parallel, and it was translated to English. It's like the ECG, so PQRST, you just add the O. So you know the ECG, you just add the O, that's your mnemonic, done. It's easier as there is no like similar letters like S is double here, so maybe you get confused. I don't know, like it's a bit difficult to memorize so many words. So this is much easier, like onset, when did it start, how long ago, what happened, did he fall down, did he eat something, is it sudden or gradual, provocation, palliation, questions about what makes it worse or better, quality, describe the kind of pain. Radiation, this also includes the site, so it's site and radiation. So where does it start and where does it go? So it starts on right flank and radiates to cubic symphysis. Yeah, severity, it's a number from 1 to 10. 10 is the most painful. And then time. So how long did it last? Does it come and go, or is it constant? So that's your time. So onset, provocation, palliation, quality, radiation, severity, and time. I think this is all the questions. Mnemonic, it's the best. Like you have all the questions, they can come to your brain. While Socrates I don't like so much. And this is internal medicine state exam questions. As you can see, we have 2 for chest pain, 2 for abdominal pain, 1 for joint pain, 1 for muscle pain. So every time you see pain, remember to go OPQRST. Like if you say, yes, okay, I have a chest pain, I'm going to ask these questions. I have abdominal pain, these questions. Joint pain, these questions. Every time you see pain, do the specific history for pain. Okay, any questions for history? Any questions up to now? No. Okay, continuing on. Going on to the physical exam. Yeah, so this is basically third year, okay? It's third year probiotics in internal medicine. That's your inspection, auscultation, palpation, percussion. You need to revise it. I had revised this in my state exam, before my state exam, and Professor Linhart gave me a clinical case. He acted as a patient, so he simulated a patient for me. And I started with the history, blah, blah, blah. And then I went to like inspection. What am I looking at? The skin, marks, ecchymosis, whatever, auscultation. Revise what is the definitions, okay? What is wheezes, what is rays, what is crackles, what is wet crackles or dry rays, blah, blah, blah. Like revise this from third year, okay? I know you're sixth year, it's been so long ago, but you should know your physical exam. So revise it and also revise the pneumonia. Pneumonia has a specific auscultation pattern. It's evolving. It's not the same sound. You cannot say pneumonia sounds like this. There is crepitus indux, crepitus redux. You should revise your Latin term, these Czech things they ask. So how does the pneumonia evolve? Yeah, and about the vitals, when you say vitals, don't just say the heart rate, respiratory rate, blood pressure. You also have like capillary refill, skin color, temperature. You have also other vitals, let's say, maybe weight. If they're having acute kidney injury and they're becoming edematous, you can ask for weight, you can ask for urine output, you know. So there's a lot of things you can ask, not just heart rate, respiratory rate, and blood pressure. These are the basics, okay, but you have so many other things that can guide you to the diagnosis or to the severity of the disease. Yeah, and some diseases, like for example, like edema, maybe you have like a huge edema everywhere. Maybe your eyes come out, or like a Graves' disease, you know, like the eyes, lagophthalmos. So inspection. Don't forget your inspection. Okay, and then this is the 2 basically type of questions you have in your state exam. You have diseases, so it's like specific disease, and you have differential diagnosis questions. So this is basically 5th year, and this is the addition to 6th year. So you don't have them in 5th, but you will have them in 6th. So how I will go about answering the diseases question, so that's 5th year as well. First, start with definition, okay? So explain the theory. There is some values, like what is the value for hypertension? What is the value for pre-diabetic? The value for diabetic? Know your values. What does it mean acute? What does it mean subacute? Because different diseases have different definitions for acute and subacute. Like some disease may say acute is less than 3 months. Others will say acute is within 72 hours. So learn your values well for your definitions, okay? These values will be useful in the classifications and severity. Like, for example, pre-diabetic, diabetic, so, or pulmonary embolism, mild, moderate, severe. Acute kidney injury, is it severity type 1, severity type 2, severity type 3? Then this part of the history, we said this is the etiology, causes, risk factors, pathophysiology, everything you're going to find in the history. Can be used pathophys also for classification, like pre-renal, renal, post-renal, or pre-hepatic, hepatic, post-hepatic, or obstructive. So you can use pathophysiology to classify the diseases, but there's also like severity. So know that there is based on pathophys, but also based on symptoms and severity or labs like creatinine level and stuff like that. So you start with your definition, your theory, you say your values, okay? Then you say etiology and risk factors. So this is points that you will be looking for in the history. So that's why it's important, because these things you will be asking for. Then signs and symptoms, you explain what the patient will look like or complain. Then diagnosis. So here is where you're going to put all your experiments, labs, and stuff, and also like try to classify it. So I'm going to do urine test. If it's less than 5 ml per kilogram per hour, then I would say it's type 1 severity acute kidney injury. If it's less than half ml per kilogram per hour for more than 12 hours, it's like type 2 severity. So the labs can't tell you what is going on with the classification severity, or like jaundice, you say conjugated bilirubin is high, blah, 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 unconjugated is high. So it's pre-hepatic, hepatic, mixed, direct, indirect, whatever. So you can use your labs to classify. And then with this classification, you can go on to treatment. It's better if you use treatment based on like the classification. So for type 1, I'm going to do conservative treatment. For type 2, I'm going to start pharmacology. And pharmacology, you know that there is first line, second line, third line. So you should know a bit about escalating the pharmacology. And usually the most invasive surgery is like the last part. So you can say, I will start with one drug, maybe do like, I will start with ACE inhibitors, then I will add some, I don't know, some ARBs or beta blockers. So you can combine the drugs. For the most important diseases and emergencies, you should know very well the classification and severity. But for other diseases like rheumatic diseases or rheumatology, there's so many information, and I don't know, like it's so much information. Just make a list of the drugs and say, we have this class of drugs. One example is this. We have this class of drugs. One example is this, because it's impossible to memorize the severities and classifications for them. But if it's an important disease, an important question that they will fail you if you don't know it, I suggest learning the treatment based on severity. So for example, acute asthma exacerbation, asthma attack. You say, if it's like this severity, I'm gonna give the, like the inhaled corticosteroids and beta blockers, blah, blah, blah. So asthma is one that you should know the severity, how to treat severity. Diabetes or hypertension, conservative. I will do my diet, do exercise, stop smoking. If it doesn't work, go to pharmacology, like diuretics, beta blockers. So some questions, it's better to go with classification and severity and then escalate them. So this is how you should answer your specific diseases question. What I'm missing here is differential diagnosis. I think you should also mention a bit like what else could it be. Yeah, but this is basically, if you say this and you speak very well about them, they will just ask you, okay, what else could it be? Tell me some differentials, and that's it. Now for the differential questions. Oh my God. Okay, so this is different. So define the symptom. Okay, so again, theory in the beginning, give the symptom. What does it mean? Is it defined by some value? For example, differential diagnosis of anuria. What does it mean, anuria? What does it mean, oliguria? So know your values, okay? So the difference between anuria and oliguria based on the urine output. So say your definition. Then make a table, okay? So it's good to make a table and have a list of all the etiologies and the differentials, okay? So all the possibilities. You can do it based on pathophysiology, which is what they liked in pediatrics sometimes, or you can do it based on organ system. I'm going to show you two examples later on. So you have first your definition, then you have a table with the possibilities. And now below the table, you should be able to say, what will I do? Because I told you in the end, there's a clinical case scenario. You can see my mouse. The professor will say, I'm a patient and I come to you complaining for chest pain. What do you do? So you should know that, is it an emergency? Should I to stabilize? So take the history, the sample one, not the full history. So say, I will ask these things. We're talking about chest pain. So also my pain history, my OPQRST or Socrates, whichever mnemonic you want. Then jump to the physical examinations, that's your vitals and stabilize. So that's your ABCDE. And once you do the stabilization, then everything else, okay? So that's why I put it above the diagnosis, because my diagnosis, this one, was everything else. So below it, I just put very fast, like ABCD, sample, just one sentence, two sentence, in case he tells me a clinical case scenario, not to freeze, to just look at it and start from there and then keep reading my paper. Yeah, so for treatment, you already mentioned the differential diagnosis. So you have a table with diseases. So what you can do is, you know that there is history first, then physical exam, then labs, then imaging, and finally special tests. So you can say from the history, I would ask for, I don't know, history of cancer to see if there is a relapse or some metastasis. And then you point to your table. You say, here, metastasis. I will ask this thing. Then you go on, like physical examination, say everything from third year probiotics, like everything you can remember, inspection, palpation, percussion, auscultation, like all the physical exam, the signs, the specific tests, the provocation test, whatever, Tabotman, Homan sign, like all these things, put them here. And this is what they will spend most of the time in, because this is what you should know. You should know how to examine a patient. Then for labs, you have a list of diseases. So you can say, I see here hemorrhagic diathesis. So I will check coagulation for hemorrhagic diathesis. So you can refer these labs to your table. So it's easier for you, and you can show it with your pen, you can show it with your finger. So he's not lost. The examiner is not lost. He has a flow in his brain. And then finally, imaging, I will do chest x-ray to see if there are any lesions. If I don't see anything, I will do CT, blah, blah, blah. And be prepared when you're explaining labs and imaging or physical exam or history, basically everything from here. They can ask you, okay, so what would you expect to find in a patient with this disease? So for example, if it's cancer, they will ask you, okay, so what do you expect in chest x-ray to find if the guy has cancer? So you have to explain your x-rays, like hyperdense, hypodense, consolidations, no, sorry, opaque for radiolucent, stuff like that. So yeah, on ultrasound, like try to find for the diseases you mentioned, what you should expect from the history, physical exam, labs, imaging, and special tests. So don't just name the tests. Know what is the answer for each disease. If you don't know, if you go to the exam and you forget, oh my God, what is the labs for this, or what is the x-ray for this, don't mention it. Make a table, make a lot of diseases, and okay, maybe write it, but don't mention it. If they say, oh, you forgot this disease, you can say, oh yeah, I wrote it down, so you can show it to them. So they will not say that you forgot about it, but don't mention it if you forget, like the specific answers, like labs and imaging, because they will tell you, oh, you mentioned this disease, what will the x-ray be? So don't kill yourselves, okay? Be smart. From the treatment, you're going to know them from the diseases question. So from 5th year, you're going to know anyway the treatment for it. Don't mention it in this question. Don't mention treatment. What they will do is they will ask you, like, from one or two of the etiologies in the table, they will tell you, okay, so for this, let's say it's this disease, what is the treatment for it? So don't go and say by yourself, it could be this disease and it will be this X-ray image and I'm going to do this treatment. Don't go by yourself into the treatment. So skip the treatment for it. But they will ask you, like for me, I had something like GERD, and so I asked history. Then I did physical exam. Then I asked for ultrasound. I asked for labs, and finally he asked me, okay, so what is the treatment for it? So it was only for one disease from my entire list. So that's how you should approach your exam. An example here, acute dyspnea. I'm gonna take my paper, write the definition on the top. What is acute dyspnea? How many months? Whatever. What does it mean, dyspnea? And I used like strong medicine on YouTube. So I saw for everything, but I didn't memorize everything. I just took his way of answering. So, for example, this acute dyspnea, he organized it based on pathologies or based on what is the labs test. If I see acidemia in acute dyspnea, then it would be this disease. So I don't like this classification. But the idea is that you make definition, you make a table, you write all the different like differentials, classify them so it's easier to memorize. If it's easier to make a mnemonic, if it's easier for you to make a mnemonic, then skip the table, just write the mnemonic and what does it mean, and then just name the differentials. Then on the bottom you have like, I'm gonna do the history, the vitals, I'm gonna do the X-ray, I'm gonna do the labs, ECG, blah blah blah, and then try to write what do you expect from each test, like for some of these diseases, and why you are checking each. So yeah, like if someone comes with a bit of fever and everything else is fine, you examine everything is fine, and you do the labs and he has like a bit high CRP, but it's more like monocytes, like lymphocytes. So you're thinking of like maybe a viral disease. If you say I'm going to check bilirubin or something, like they will ask you why, like what the hell, like why? So it's not needed. It's wasted money, wasted time. So just have an explanation why you are saying the labs. Say the labs that make sense, okay? And then yeah, that's on the side. Like I'm gonna see this on the X-ray. If I see this on the X-ray, what does it mean? You know, like try to put your explanation why you're doing the test and what do you expect to find in this test. But if you just say definition and make this table, you are halfway there. Just say history, physical exam, labs, imaging, and special tests. You go down this way, and then you start putting some examples, say a few questions, why you're asking these questions, a few physical exams, what are you checking for, which provocation tests are you doing. So try to explain it, give your logic. If you give your logic, that's good. And don't forget the common ones, okay? Don't put in your list rare diseases and then forget to put the common ones or the emergency ones. Make sure that your table has all the common ones and emergency ones, and then you can add the less common ones. That's the most important, okay? You don't have to have like 30 differentials or 50 differentials. Just have like, I don't know, 15, 10, 15 or 10 or something, of which the 5 most common and then the 5 more emergencies. And no, wait, we have 10, 3 most common, 5 most common, and then 2, 3 emergencies, and then the rest you just put what you're comfortable with. So start by putting your emergencies and everything and common. Otherwise, they will tell you you forgot something very important. And then you're going to stuck there in the exam and they will ask you, okay, not this one, not this one. What did you forget? What did you forget? And then you're like, oh shit, atrial fibrillation. It's very common and I forgot about it. So put your most common and your emergency ones. Okay, then some symptoms like chest pain could be emergency. So for emergency symptoms, this is Professor Linhart. This is his lecture, Differential Diagnosis. You can find all his differential lectures here on medical media, but you have to log in with SIS, okay? So it's only available for LF1 students. So some diseases, they look similar, they manifest similar based on symptoms, but they're all emergencies. So there is something pathognomonic for each, like, and you should know how to differentiate them, basically. Know specifically how to distinguish between them. So like the ECG, maybe the CT, yeah. So if you have emergency things, know very well how to differentiate them. What is the differences? So for example, here, this is from Strong Medicine, not from Linhart. It says chest X-ray. This is a differentiation. ECG, this is a differentiation. Physical exam, it will be like this. So try to differentiate the emergencies, okay? And again, make your table. This is based on organ systems, cardiovascular system, what could it be? Pulmonary system, what could it be? And then he subclassified based on anatomy, pleura, airways. So basically find your own classification that you can memorize. You don't need to have all of them, just have a structure. So from esophagus, you can have like GERD and esophagitis, done. From stomach, you can have like peptic ulcer disease and done. So if you show your logic that it could be GI, it could be from stomach, could be from esophagus, you don't need to name everything. Just show your logic. And yeah. And why are we doing DVT and pulmonary embolism? Because they're many times examined. Remember that pulmonary embolism is part of the obstructive shock, right? So even the questions that have shock, they can ask you for pulmonary embolism because of the obstructive. If you go on the shock, obstructive, like pregnancy, shock in pregnancy, some obstructive, pulmonary embolism of amniotic fluid or something. Surgery, gynecology, state exam, internal medicine. So you have a lot of questions they can ask you about pulmonary embolism. So here is internal medicine. This is our question, and they put them together. So I think they mean that pulmonary embolism, you should focus on the deep vein thrombosis cause of it. There's many causes, but focus on deep vein thrombosis. They don't have time to go through all the pulmonary embolism. Just start with deep vein thrombosis and then escalate it, like continue on to pulmonary embolism. I know people who failed surgery state exam for not classifying properly pulmonary embolism. So yeah, like it's not an internal medicine disease. It can be in surgery as well, and also gynecology. For this question, I know a classmate who had a problem with this. It was gynecology, and he started talking about amniotic fluid embolism. And then the professor said, I'm sorry, but this is obstetric, not gyne. So I want some thromboembolism in gyne. And the first thing he came to his mind was like oral contraceptives. And he said oral contraceptives. And the professor said, no, it's not so like, let's say, important because it's only 1 to 2 times more than the general population, the risk increase. So what else is most common? What else should you think about in gynecology? And eventually the answer was there was a tumor in the cervix or something, and it was compressing the iliac vessels, the veins there, and the stasis made the deep vein thrombosis, and then that one made the pulmonary embolism. So yeah, so it's also gynecology, also surgery, also internal medicine. Just know it very well. That's why I'm doing it today. I spent so much time explaining internal medicine state exam. Okay, so let's go to theory fast. This is from second year. Thrombus and third year as well. Thrombus, you know that it's the final product of coagulation. There is white and red thrombus. So white because it's platelets, usually found in arterial blood, so the arterial side of the system. This is treated with antiaggregation. Okay, so antiaggregants, the platelets and stuff. While the venous, it's basically the red one with stagnation. So the red blood cells, that's why it's red. We need anticoagulation. Okay. The only, let's say, part I found that was not veins, it was atrial fibrillation, that you also give anticoagulation. Do you know CHA2DS2-VASc score and Hasbled score? Do you know what is the difference for the 6 years?
I know the CHA2DS2-VASc score. It's used in atrial fibrillation, but not the Has. What is that?
Okay, so what do you mean for atrial fibrillation? What does it show us?
So you use it if you need to give them anticoagulants, like you assess the risk of a patient with atrial fibrillation if you should provide them anticoagulation.
Yes, so it's the risk of
Developing a stroke.
yes, so
typically.
embolism, thrombosis and stuff. So why not give to everyone? Just give to everyone. Why do we have to score it? You
No,
get
well,
an
atrial
interest.
fibrillation is very prevalent, right? So you don't want to give it to everybody.
Okay.
It's
Yeah,
anticoagulants also has side effects, so yeah, you want to assess.
exactly. So the answer is risk to benefits, right? So
Yeah.
then we have a score, we get the number, but you should also know Hasbled score. Okay, study Hasbled score. It's especially Professor Linhart or any cardiologist. So this is one side. This is saying the score that you have to give anticoagulants because it's going to coagulate the blood and get the stroke. And Hasbled is the opposite. It says that it's the score that you are going to bleed with the anticoagulation. So you need to make the scores and find like the benefits to risk, which score is more. So if this guy is going to bleed, and he has a very low score for having a stroke, you will not give him anticoagulant because he's going to start bleeding spontaneously and he will die from hemorrhagic stroke rather than ischemic stroke. So I would suggest you revise also Hasbled score, okay? So this is the opposite of Chad's VAS score. I think I'm missing a V here. Chad's VAS. I think I'm missing a V here. Okay. Yeah, it may propagate. Know that the thrombus can grow and grow and grow. Okay, it's increasing in size, and then eventually it blocks the flow. And the emboli is a complication. Okay, so embolism is a complication. When we talk about deep venous thrombosis or basically thrombosis, we only talk about the first part, blockage of venous blood flow. This is the first disease. It has its first, let's say, symptoms and treatment, blah, blah, blah. But embolism, we jump into another disease, okay? It's a complication. It's not the same disease. I know it's the same pathophys. It's like continuation of pathophys, but it's different disease, okay? Embolism than thrombosis. Now, the embolic part is going to come out and keep going downstream from the arteries, and they get smaller, okay? So they get stuck in the capillaries. So this is like some systemic artery or capillary. It gets stuck there, this embolus. But the veins, they get bigger and bigger. So they cannot embolize in the veins. What happens is that then they switch to the arterial system again, and it's again capillary. So that's pulmonary artery and capillaries. So it's at the end of the artery. They get blocked when they go from artery to capillary, okay? You cannot say it's going to embolize into the vein because the vein is getting bigger and bigger as it goes downstream. Causes and risk factors, virtuous triad. Do you remember virtuous triad? Do you know what is it? What are the three things for virtuous?
Stasis, endothelial damage, and I think increased risk for something.
Yeah, hypercoagulability, whatever.
Yeah.
So if you know these things, you know the risk factors and the causes. Just know this triangle, try to put as many things as you know inside this. This tumor compressing vein is part of the stasis. So this is what was asked in the gynecology state exam, that actually some tumor or some mass, whatever, can compress the vein. It's going to be stasis. And also know that venostasis will make problems on the skin if it's in the periphery. And here, yeah, different, just put the triangle and that's your risk factors and your causes. The coagulation cascade, we have some tests, APTT, PT, INR, APTT ratio. Do you know what these are and when do we use each test for?
Prothrombin time and partial tissue thromboplastin, right? Yeah.
Yes, when do we use them? Like intrinsic or extrinsic? Which diseases? What are we monitoring?
Yeah, correct.
Okay, I'll give you the answer. But can you tell me the vitamin K dependent factors at least?
Yeah, 10, 9, 8, and 2.
No,
2,
not 8.
7, 9, 10.
Yeah, 10, 9, 7, 2, S and C. Don't forget protein S and protein C, okay? And is it, yeah, I'll give you here everything. So this is extrinsic. So PTTT, that extrinsic, APTT is intrinsic. So APTT, hemophilia, heparin monitoring, okay, intrinsic pathway, okay, plus the common. Yeah, so that's APTT. There's also something called, if you look at here, it's a APTT ratio. It's something similar to INR. So PT or quick, it's for the vitamin K dependent factors, coumarins, warfarin, liver synthesis activity, fibrinogen abnormalities. So INR, you just take the patient over the standard and you have a ratio. That is the same for APTT, okay? So INR is the ratio of PT and APTTR is the ratio of APTT. This is the coagulation screen. When you say I want to check coagulation, you get this blue tube. I don't know if you did rotations. Of course, you did rotations in hospitals. You saw it already. You're going to see fibrinogen, prothrombin time, INR, APTT, and APTT ratio. And then from another tube, you're going to get the platelet count from the total blood count tube. So platelet count is part of the coagulation screen, but I think it's different tube, if I'm not mistaken. Yeah, so all of these factors, you just look at them and you can evaluate the coagulation of the patient. This is a new thing. You can do it at home. You can find INR at home. Okay, so this is a new thing. Like for people that are, it's really important to know that their INR all the time. Then they have this at home. It's like a glucose meter, like in diabetics, that they just put their blood and then the result appears, but for coagulation, for INR. So know that this technology exists. Coagulation cascade. Do you know the types of heparin? Or what is the side effects or some toxicities of heparin? What should we be scared of from pharmacology fourth year? Types of heparin?
Yeah, there's low molecular weight heparin and I guess normal heparin. Yeah.
Not normal, but high. It's here. High molecular weight.
Okay.
Fractional weight. Yes, okay. And do you know how to, what is one toxicity or side effect, like something to worry about to stop heparin? You say, oh my God, we have to stop heparin. Some disease maybe.
Yeah, a colleague mentioned heparin-induced thrombocytopenia. Yeah.
It's here. Aditya. Oh yeah, Aditya was right. Heat. Yeah, heat. Good. Okay, I'm sorry. I'm not looking at the chat. Yeah, that's good. Heat. Okay. How do we monitor heparin and how do we monitor low molecular heparin? Do you know their antidote? How do you reverse heparin effect? How do you monitor it and how do you reverse it?
So yeah, the answers are in the chat again. Yeah, you can check it out.
Protamine sulfate, correct. Anti-XA, yeah. APT, yeah, good. Yeah, you are very good. You are very good. Okay, and which are the contraindications for the direct oral anticoagulants or novel oral anticoagulants? Now they call them non-vitamin K, like N, they keep changing definition, but let's call them direct. So direct oral anticoagulants, contraindications, when you cannot give the DOAC. It's also for surgery as well.
Low GFR. Yeah.
Okay, that's mechanical valves. You have mechanical valves, it's contraindicated. Okay.
Mm-hmm.
So that's why it's surgery as well, because you have cardiosurgery questions. Yeah, heparin, we have here, you can use osmosis or something like a book. Heat, revise your heat. Like, what does it mean? Okay, like a bit of, not completely crazy on pharmacology, just basics, only basics. Yeah, okay. And then we said heparin, APTT, low molecular weight heparin, anti-XA, okay, monitoring. Yeah, you know what is breaching? Have you seen breaching before? Like, what does it mean, breaching? Protamine sulfate, antidote for both. Bridging.
It's like when you convert from one to another, like.
Not convert, but covering. You know that warfarin, it's also S and C, like this mnemonic, I don't know if you've seen it before. It means 10, 9, 7, 2, protein S and protein C. So that's like, if you remember this date, 1972, if you remember this date, it's basically all the coagulation factors. Yeah, so when you have warfarin, it's going to, you can see it here, protein C and S are anticoagulants and they disappear first. So you have the procoagulants remaining in the circulation. So you have a period of being like a bit more procoagulation plus the warfarin takes time to work while heparin is immediate effect. Yeah, so you have like usually 5 days, give low molecular weight heparin, it's an immediate effect, and then you put it until the warfarin starts to work or until INR is 2.5. That's about 5 days. So INR 2.5, 5 days, then it means the warfarin is working, so we should stop the heparin. This is what is called bridging. You should know this from fourth year in pharmacology. Yeah, the treatment, the dosage for warfarin, usually it's minimum 3 months. So it's 3 to 6 months. How long do you give warfarin? 3 to 6 months. Unless there is some other disease or it's very high risk, then you can give it forever, okay? So if they ask you like some proximal DVT or thrombosis, how long would you give warfarin? You don't say 1 month, 2 months, or like minimum 3 months. So 3 to 6. You say between 3 to 6, then that's good. If they tell you that if you go to the thrombophilia question, there's another question of thrombophilia. You will not say 3 to 6 months, you will say forever. So it's like prophylaxis. Yeah, okay, just know that warfarin is contraindicated in pregnancy. That's for your gynecology. So what am I giving instead, if not warfarin? Which anticoagulant am I giving for pregnant women?
Heparin?
Yeah, low molecular weight heparin, good. DOAC, I don't know. DOAC, I don't know. I know for sure low molecular weight heparin. I don't know DOAC, maybe. I don't know, why not? Don't you far? Okay. People writing, okay. Good. Moving on. So this is basically revision, okay? What are D-dimers? What is their usage and clinical significance? Do you know what is D-dimers? Like, how do you use them?
Yeah, they're the end products of fibrinogen, like when you break down fibrin, right?
Plasmolysis? No, thrombolysis. Yeah, thrombolysis. End products of thrombolysis, let's say.
Okay.
Okay, but how do you use them?
Yeah, you use them in pulmonary embolism, definitely, and any other cases of emboli or thrombosis.
Okay, but how do you use them? Like, you make a test, okay, and I see that they are, for example, 600. What does it mean? I see 600 D-dimers. What does it mean? What information do I have? Diagnosis from it. High D-dimer means high clotting, so can be pulmonary embolism. Okay.
But it's non-specific, right? Like it's
exactly.
elevated.
That's what I was looking for. So what is it called? I think you did it in hygiene state exam. They are high negative predictive value only. Okay, only negative predictive value. So it means low is not DVT, but when it's high, it can be many things. We just use it for exclusion. If the D-dimers are low, you exclude it. If the D-dimers are high, you don't know what the hell is going on. You cannot give diagnosis. Normally it's 150 to 200. DVT is more than 500. Pulmonary embolism is more than 1,000, even more than 6,000. There's also many other things like surgery, trauma, stroke, infections, malignancy. So if it's high, it's unusable. If it's low and negative, it's very usable and we make exclusion, okay? Yeah, alteplase is the TPA, tissue plasminogen activator, the drug, alteplase, can be systemic as well as catheter directed, so localized. So depending on where the thrombus is and if we have access for it and the clinical situation, it can either be systemic thrombolysis or localized thrombolysis, okay? It's used for if there is slow response to anticoagulation, we need to make it faster because usually what we do is if it's not so severe, we just give the anticoagulation. So it means that the thrombus will stop to grow. It will not grow anymore. And slowly it will dissolve by itself. But if it takes too much time for this natural process of self-dissolving to happen, then we activate it ourselves. We use alteplase, the tissue plasminogen activator, and we go there and we destroy it ourselves. We don't wait for the natural dissolving of the thrombus, okay? But usually we just give the anticoagulation and we wait. If it's very slow or it's pulmonary embolism with unstable hemodynamics, I'm not going to sit down and wait for it to dissolve. I'm going to give alteplase and destroy and remove the obstruction because pulmonary embolism is obstructive shock, right? So the treatment for obstructive shock is remove obstruction. So give the alteplase. Don't wait for the slow dissolution of the thrombus. And the location. So if it's well-defined proximal iliofemoral DVT without risk of bleeding, then you can do is localized with a catheter. You just go there from the leg, from the iliofemoral vein, and you go upwards and you just put it with the catheter. Okay, so that's the D-dimers. Very important to remember that it's high negative predictive value only, and we're going to use it in our algorithm. Okay, I'm going to give you an algorithm. Any questions on theory? Any questions on the theory part? And then we go to DVT.
That's okay. Yeah.
Okay, DVT. So DVT, deep vein thrombosis. So deep veins can be anything, right? It's not legs. It's not hands, it's not in the neck, it's not jugular. It's anything that is deep veins, basically not superficial, okay? So when you go to surgery, and in surgery we have a part of the exam is cardiovascular surgery. The cardiovascular surgeon has access to all the vessels, okay? So the question DVT in surgery involves also like superior vena cava, inferior vena cava. But now we're going to talk a bit more about the legs because we are internal medicine and we should know the legs more, what is happening in the lower limbs, because it's the most common, okay? So it's any deep vein, not just the legs. Deep vein thrombosis, okay? Any deep vein. Why is it especially on the left leg? We have the May-Turner syndrome here. We see that the artery here is compressing the vein, and this makes the stasis. So that's why it's thrombosing here. Okay, that's just know that this exists. If they ask you left leg, right leg, just know that it's the left leg because of this anatomy. Am I going to use antiplatelet or anticoagulation for DVT?
Anticoagulation.
Exactly. We said it already. It's just a revision. We said venous, anticoagulation. Okay, if it's in the vein, it's because of the red thrombus, anticoagulate. Okay, anatomy. So we have superficial veins. They drain the femoral vein over there and the popliteal vein over here. So they go in the deep. So this is the deep veins of the leg. Okay, not the superficial, the deep. Now, when we go to see the deep veins of the leg, we can classify them into proximal and distal or crural. This is the crus, calf. This is from the lecture. So they have also secondary idiopathic, but I don't care for this. I care about proximal and distal. Let's go the anatomical way, because the anatomy is where you're going to examine it yourselves. So it's physical examination and also prognosis. So distally, its danger of pulmonary embolism is low, as well as the recurrency rate is low. So if you come to the crural part, distal deep veins, it's the most common thrombus, but they are non-embolic. Okay, they just have some thrombus there, then they dissolve. That's it, problem solved. But they may extend proximally, so they can grow. If you have the risk factors and they remain there, can grow, and eventually it become, because the more you move proximal, the bigger the vein. Okay, and then maybe it can embolize. So these are the bigger veins of the leg, the iliacs. They are the most common to embolize. Okay, so just know a bit your anatomy of the veins of the leg, the deep veins, and yeah, that's it. Now a bit about the non-leg deep vein thrombosis. I will not go into details. You have it here. You can take a photo, screenshot, whatever. You can find it on YouTube and look at it at your own time. This is for surgery state exam, not internal, okay? So they care also for superior vena cava, for inferior vena cava. Difference is upper limb, lower limb. Yeah, and we use anticoagulation as its veins, of course. And remember, a new point here is that if it's chronic thrombosis, there can be time for collateral, so it can be asymptomatic, okay? So just know that if the thrombosis is chronic, it could be asymptomatic. And then we have pelvic veins. This is also for surgery. They will ask you how to do these procedures and stuff, but this is surgery state exam. Maybe we can discuss it when the time is near. There is chronic closure and there is also acute closure, okay? And I don't know if I think these terms are also in internal medicine. Phlegmasia alba dolens and phlegmasia coerulia dolens. It means painful white inflammation, painful blue inflammation. The difference is that the white is in deep veins and the superficial and the blue one is in superficial veins, okay? So you can have a look at them on your own time. Now let's go back to the leg DVT, which is what we care. So maybe asymptomatic, we said, if it's small calf veins, if it's here, asymptomatic, non-embolic, okay. If it takes days for thrombus to become symptomatic. If it's chronic occlusion, then there can be collaterals. So it actually depends on the occlusion percentage and speed. Same like arteries, like it depends on the occlusion percentage and speed of formation. Typical symptoms. You should know the typical symptoms very, very well. So we have swelling, pain, tenderness, pain. So what does it mean, pain? Take the history for pain, okay? Whenever you see pain, take the specific history for pain. Onset, radiation, and all the stuff. Tenderness. What does it mean, tenderness? What is the difference between pain and tenderness? Okay, tenderness is when you stimulate it, right? When you touch it, when you try to stimulate it. And we have this one, you should know from third year. It's called the Homan sign. Is we have a pain here on the leg when you make dorsiflexion. So if you make this one and there is thrombus there, it's going to make pain. That's the Homan sign. There's also something called Pyre sign. It's basically pain on the sole when you pressure on the sole. But both of them check the same thing, tenderness, which means pain or stimulation. Okay, pain or stimulation, try to stimulate it. If there's pain, that's it. We had a patient in the clinic for my rotation in internal medicine. And all the students were doing the Homan sign, on the patient all the time, and the patient was exhausted and in pain. So we recommend, if you have a diagnosis already, stop doing it because it's very painful. So yeah, do it once, make your diagnosis, and stop doing it. Don't let medical students do it all the time to the same patient. Yeah. Okay, so this is tenderness. Then you have also, it's warm and cyanotic. In arterial one, if you have arterial blockage, it's called pale and non-swollen. Why is it called and pale if there is arterial disease? But if it's venous disease, it's warm and cyanotic.
In arterial, there is no more peripheral blood supply, right?
Yes, so there is no warm blood coming, so it's cold and pale. While in venous, basically it's venostasis. So the artery blood is keep coming. So it's warm. The warm blood is coming and coming, and it's gonna look cyanotic, maybe red. And then because the blood is coming but not leaving, then you have superficial veins distended. Okay, they try to go back to the heart via a different route. So remember these signs. If you understand the pathophysiology, if you understand how it works, these typical signs, that's amazing. And then the less typical signs, it depends. If you have pulmonary embolism concurrent, you will have symptoms of pulmonary embolism. If it goes the upper limb, but we're talking about leg, so we don't care about this. Maybe some fever, but don't mention it because, yeah, I wouldn't mention it. I will just stick with the typical symptoms here and compare it with arterial blockage. So they can ask you, how do you know it's venous, not arterial? So you can say this is the difference. Okay, know how to differentiate. Yeah. Clinical approach to DVT, it's an exclusion. Okay, it's a diagnosis of exclusion. So there is something called Well score. It's used for pulmonary embolism as well, but there is another Well score for DVT, but it's not used in our faculty in Czech Republic. So briefly, how it works is that you get 1 point for each of the 9 risk factors, but if a differential is more likely than DVT, you remove 2. So if you have 0 risk factors and another differential is more likely, that's actually -2. And if DVT is very likely and you have all 9 risk factors, that's 9. So the score is from -2 to 9, maximum and minimum. 1 and less means unlikely, 2 and more means likely. Okay, so that's a Well score for DVT, but we don't use it. Extra diagnosis, so try to find the cause, differentiate, exclude DVT, do your history. And we said pain, right? So pain history as well, physical exam, do some clotting labs, some tumor labs. So you can go this on your own, use logic, and you can find it. D-dimers, what does it mean, high negative therapeutic value? We explained it already. It means that low is not DVT, but high can be many differentials. So in general, it's done, the D-dimers, to confirm exclusion, right? That's why it's negative, confirm exclusion, not to confirm diagnosis. When do we do it? When we have low suspicion, to confirm the exclusion, so to confirm our low suspicion, or if we do a specific test like negative duplex compression ultrasound. So we did the ultrasound, it's negative, we don't see like DVT signs, but we are still high suspicious, then we do it to confirm the exclusion. So the point from here is that if you do ultrasound and it's negative, you can not exclude it. You can still not exclude it, okay? Negative ultrasound does not exclude it. Only thing to exclude it is negative D-dimers. So imaging for DVT and pulmonary embolism. Now let's go, we're going to do them together. DVT, the golden standard is duplex compression ultrasound. So these are the findings. The vein will be obstructed, non-compressible. There will be abnormal Doppler flow, some hyperechoic mass, okay? Contrast venography is the gold standard, but we don't use it. You know, we're not gonna do contrast venography. We just use duplex compression ultrasound. That's faster and more comfortable. And then for pulmonary embolism, what we use all the time is CTPA, pulmonary angiography, CT pulmonary angiography, except when there is some renal or contrast allergy to the contrast because you are doing angiography, then we can use VQ scintigraphy. When the patient is pregnant, we cannot use VQ scintigraphy, okay? Just remember these two. Chest X-ray, learn how it looks like, but yeah, you can do it for low suspicion and low risk. Just do a chest X-ray, be done with it, see what's going on. Okay, now important is cardiac echo ultrasound for pulmonary embolism. We're talking about pulmonary embolism here, not DVT. Cardiac echo ultrasound is usually done for unstable patients. They don't have time to go to CTPA. Just do the echo ultrasound and try to find, what are we trying to find with cardiac echo ultrasound on pulmonary embolism suspicion? Do you know what signs or what are we looking for? Can over manipulating of the leg. Can over manipulating of the leg when diagnosing DVT increase risk of clot breaking and embolism? Yes, but it's more important to get a diagnosis so you can prescribe the anticoagulation. If they're already in the hospital and you're doing your diagnosis, I think it's no problem. Dilation of right ventricle. Okay, Aditya, what are you actually looking for? Like, what does it mean, dilation of right ventricle? Like, what are you looking for? What is that say the disease or
You're
why
looking
dilation
for
of right ventricle?
pulmonary, maybe? Yeah.
Yeah, exactly. Okay, good. So it's obstructive shock, obstruction. The heart, the blood cannot pump to the lungs. It gets stuck there, comes back. Right ventricle, back. Right atrium, and keeps going back. So obstructive shock. Need to remove the obstruction. Okay, good, excellent. You're very good. This is my little diagram. If you want to take a photo, memorize it. If you know this, that's it. I think you can find it in many books as well. So suspected DVT. So this is for pulmonary embolism. This is for just DVT. Okay. We have some specific tests. If you have high suspicion for pulmonary embolism, do CTPA. High suspicion for duplex compression ultrasound. High suspicion for DVT, do duplex compression ultrasound. Okay. So these are the specific tests. Now, always do specific tests if the D dimers are positive. So if you go down to the D dimers and they're positive, you jump to the specific test. You go down the D dimers pathway, it's positive, jump back to the specific test. And when you have high suspicion, you do specific test. High suspicion, you do specific test. Okay. Now, for the negative specific test for DVT, you cannot exclude it, only with D dimers. So if you come to the specific test and it's negative, you do the D dimers, okay? If you've not done already. So it's going there. But the CTPA, if it's negative, you can exclude it. That's the difference, okay? CTPA pulmonary embolism negative can exclude, while duplex compression ultrasound for deep venous thrombosis negative cannot exclude. Go to your D dimers. Okay, it's a little nice diagram. Know that in pregnancy, use CTPA. If it's unstable or unavailable, do the echo ultrasound. It's faster. In contrast allergy or renal insufficiency, use VQ scintigraphy. Okay, I think this is super summarized. If you do this, that's it done. You know your diagnosis, what does it mean? I think it's a good summary. And you can use it for DVT and pulmonary embolism. If you know this, you're covered. Yeah, so this is pulmonary embolism or not, suspicion, and then the result. Okay. Treatment for DVT, we have some special treatments. So like selected patients, they have some special treatments, but most patients, you just do anticoagulation. Okay, you just give the anticoagulation and wait for the thrombus to dissolve. Then you also give secondary prophylaxis. Okay, so secondary, why? Because they're patient. So it means they already have it. It means they had already DVT. And now we need to prevent the secondary DVT. While primary prophylaxis, if you see here like a primary prophylaxis, it means that they didn't have DVT yet. They're just high risk. For example, someone going to surgery, they're 25-year-old or whatever, so they're doing surgery. You can use some compression stockings when they go there. So this is primary. They didn't have it yet. While secondary prophylaxis, is what you do after the patient is treated for DVT. So start with anticoagulation, heparin, warfarin bridge, warfarin for 3 to 6 months. That's your secondary prophylaxis. You have mechanical prophylaxis and pharmacological prophylaxis. Elevate the limb, compression stockings, maybe pneumatic stockings, early mobilization, so get them out of the hospital as fast as possible. And you have your anticoagulants. So anticoagulants, secondary prophylaxis, most patients. Then the minimum duration 3 months, 3 to 6 months is your warfarin. Okay, contraindicating pregnancy, use low molecular weight heparin. That's it. Going now to selected patients. So we said already about alteplase, can be systemic or localized. When do we use it? Already mentioned. Thrombectomy. Okay, this is rare, but is used in surgery state exam. It's examined on surgery state exam. There's something called Fogarty catheter. Okay, it looks like this. You just go there inside. This is your catheter. Then you open the balloon and then you put it back. But the thing is, in the surgery state exam, they tell you it's a catheter, so it means there is a hole on the tip, and it is connected to our side, and what fluid is passing through. Because if you know, like urinary catheter, the urine passes out. So this is a Fogarty catheter. So they will ask you, what is the fluid passing through? Why is it a catheter and not like a stent or like a metal wire? Why does it have to be a catheter with a lumen inside?
Is it the thrombus with the blood or something?
So what do you mean, thrombus in the blood?
Yeah, because you're thrombectomy, right? So will the thrombus come with the blood, like the thrombus that you're trying to remove?
Okay, thrombectomy, this thrombolysis is this one. You just put it in, there's a lot of holes, and you put the alteplase in, and it will start to dissolve it. This is thrombectomy. So you go in, the balloon is on the other side, you inflate the balloon, and then you pull it back, and the thrombus comes back. Okay, there's also a net here. There's a net, like an inferior vena cava filter, you know, this net, this filter.
Yeah.
It also exists here, so the filter will pull everything. But what fluid do you think will pass through? Are we injecting something or sampling? So you think that we are sampling the blood? We put a catheter to take
It is
the
in the
blood.
blood, right? It's going to the
It
blood.
is in the blood, but am I going to inject something in it or I'm going to pull something from it?
Maybe you inject something, I think.
Exactly, inject. And what do you inject? Okay, I'll give you the answer. It's contrast material because this is done under radiographic control, right? Under X-ray control. So how do you know if you are past the thrombus or behind the thrombus? You don't know because the thrombus is not visible on the X-ray. It's the same with coronary angiography. You know, you go there and then you inject the contrast to see if you are actually in the coronary artery. So it's something similar. You inject the contrast material, this contrast fluid, and it will appear on the X-ray. You know, the one you are looking at, this live X-ray image, the video X-ray. And you're going to see that the contrast is going and coming back, going and coming back, going and coming back. Then you enter inside, and then it's going and going on the other side. So you're like, okay, so it means I passed the thrombus. So now it's time to inflate the balloon and come back. Okay. So this is for surgery state exam, but I'm telling it now so you're learning everything at the same time. Interesting.
Yeah, definitely. Yep.
Okay, so this is the indications when to use it. In inferior vena cava filter, we usually use it when you have contraindications to anticoagulation or thrombolysis or thrombectomy. So it's like a last resort. And you have to remove them as soon as possible because if it stayed too long, there is some complications happening. Okay, so it has to be removed. Inferior vena cava filter, it's a last resort. So first anticoagulation, second thrombolysis, third thrombectomy, and last it's inferior vena cava filter. Okay, complications, acute and chronic. Acute is the pulmonary embolism, of course. For chronic, you should know this one. No chronic thromboembolic pulmonary hypertension. I think there is a question about it, if I'm not mistaken. And then this is post-thrombotic syndrome. This is localized, okay? So it means it's on the skin as well. Venous ulcers from stasis, hyperpigmentation. So there was a nice mnemonic at EDU, edema and pain, dermatitis and trophic changes, and then ulcers from the leg vein. So EDU was a nice mnemonic. I used it. So have a look at it, post-thrombotic syndrome and chronic thromboembolic pulmonary hypertension. This is complications of DVT, okay? And reminder, in real life, you go with ABCD approach, okay? Stabilize, diagnose. So it's not like, okay, I'm going to do D-dimers now. I'm waiting for my diagnosis. I will not start my treatment until the D-dimers come back. No, you just go, suspicion, do your echo, do your CT, okay? CTPA, try to act fast and stabilize, intubate, oxygen. The patient is in pain, give painkillers. Saturations are low, you know, like whatever. But we're talking about DVT, so they will not be so severe. They will have pain, it will be more localized. Okay. Questions for DVT, and then the last one will be pulmonary embolism. I think it will be fast. Inject epinephrine. No, not epinephrine. Pull, not inject. No, we said okay. We said the answer. I'm sorry, I'm looking at the chat late. Any questions?
No, it's fine. I think you can go ahead. Oh wait, I think Aditya is typing. Yeah.
That's DVT, and then finally pulmonary embolism, and then we're done. We can leave. Okay. No questions. Thank you. Okay, good. Pulmonary embolism. So pulmonary embolism. See this one? Obstructive shock. Okay. Obstructive shock, emergency, need to remove the obstruction. It's part of the tension pneumothorax, pericardial tamponade, you know, like differentials of obstructive shock, and know how to differentiate like this shock versus the other shocks. Okay, so it's part of the shock as well. Shock questions. Yeah, relief obstruction is a treatment. The question is how fast are we going to do anticoagulation and wait for the natural dissolving of the thrombus and embolus, or are we going to activate thrombolysis? Okay, relieve the obstruction is a treatment. Now the question is how fast. Yeah, people fail on classification of pulmonary embolism, and that was a surgery state exam. So imagine if you don't know the classification internal state exam. ESC, do you know ESC? European Society of Cardiology. They have an application for iPhone, iPad, Android. So you have this application, and the guidelines keep updating. Okay. And how they give their recommendations is that there is the green one, it is recommended or indicated, and the red one, like contraindicated. And then yellow and orange is that we don't have a lot of evidence. So just look at the green and red. Don't bother with the yellow and orange because it's for specialization. If you're going to use this application, just look at the green and red, okay? But I think you don't have time. You don't have time for it. You should have done it in 5th year. Yeah. So causes, same, virtuous triad for the DVT, okay? The most common. So virtuous triad is for the DVT, which is the most common, but also we had fat embolism, like some surgery. So this is your surgery state exam. Amniotic fluid, air, cement, some tumor. That's for your gynae exam and surgery exam. But now we are doing internal, and the question says specifically DVT and pulmonary embolism. So let's focus on DVT. If the question is DVT and pulmonary embolism, we don't have time to talk about everything else. This is the pathophysiology to symptoms, like how do the symptoms come up. So there is your occlusion, that's your obstructive shock. Inflammation, so you have these symptoms due to inflammation, and also surfactant is destroyed. Then you have the oxygen, hyperventilation, alkalosis, okay? The CO2 can still diffuse. You lose this acid because CO2 is like the acid, right? So you lose it, respiratory alkalosis, because you don't have oxygen and you hyperventilate. Yeah, and then VQ mismatch, another part of the pathophysiology, and then you said already the core, the cardiac output, the right ventricle. This is important for echo, okay? Not only for echo, but also for the shock, because we're talking obstructive shock. So that's why we have high heart rate and low blood pressure. So shock with high heart rate. Okay, good. Symptoms. Remember, acute onset. Don't just say, oh, dyspnea, tachypnea. Just say acute onset. It's acute onset, okay? It's an emergency. The lungs, we have these symptoms. Nerves, we have these symptoms. The heart, these symptoms. If you have associated DVT symptoms, like if this was the reason, you're going to have this on the legs as well. The same way in DVT, we said maybe you have concomitant pulmonary embolism. So just know which symptoms go with which. This is less common, subfebrile, and this is least common, like if you have a subdural embolus and stuff. Just know like this very well, okay? If you know this very well, maybe subfebrile as well, then you're covered. Acute onset though. Physical exam, know what is the findings on physical exam. know the vitals, how will the blood pressure be, how will the heart rate be, what happens to the respiratory rate, temperature, we said subfebrile. Yeah, so know your physical exam. And then the general algorithm for diagnosis is that you do the physical exam, history, follow the ABCD, right? Stabilize and everything. And then because it's pulmonary embolism, we had the diagram before, I'm gonna show it again. We can do CTPA, echo, D-dimers, and troponin I. And you're gonna ask me, why are we doing this? Echo, stop. Okay, echo activate. Yeah, so yeah, so we have this test. Do you know why we do these tests?
Yeah,
Okay, echo, you said already. You said already, echo. Someone said already. Echo is for the blockage, right? So right atrial pressure signs. Why D-dimers and troponin I?
because you want to rule out MI as well, acute coronary syndrome.
Okay, yeah, it's for classification. But troponin I will be high or low in pulmonary embolism?
It could be as well, right? Because I could be right heart failure, maybe. I don't know.
Exactly. So if it's positive, it means super severe. So it's for classification of severity, and this is why we need to classify it, okay? CTPA is the most common, but if it's massive and you have to be fast, you just do the echo and start the thrombolysis. You see, lysis, thrombolysis, not anticoagulation, thrombolysis. You need to dissolve it. It's emergency. Don't just stop the coagulation and wait for the natural dissolution. Go by yourself and activate the dissolution. Or embolectomy, okay, it depends. This is a surgical approach in the ICU. So let's go to the classification. No, extramortalities, ECG, know what could be on the ECG for the pulmonary embolism. Chest X-ray, how does the chest X-ray look like, you know? And then there's also the bloods. We're gonna say now, ABG, we said already, respiratory alkalosis, okay? And low PO2. We already said about this. So yeah, tests you can do. Yeah, algorithm, first we need to classify it. Okay, this is the ESC, and this is what Professor Linhart taught us. That's what I learned. This is what Dr. Crowell from the Third Internal Clinic taught me in my lesson. He said you have to do risk stratification, which is basically this one, risk stratification, based on these things. And then he said it's massive. He explained what is massive. Then submassive, there's high risk and low risk, and then he went to chronic. So he explained chronic here, and it's not in the guidelines for ESC. And if you go to Wikiscripta, they have like massive, submassive, subacute, chronic. So I'm like, okay, so they have like chronic, so I should also add the chronic. So what I did is I used this one and added on the bottom also chronic just to be complete. So first one for risk is shock or hypotension. Shock or hypotension, it means systolic pressure less than 90. Next one is PESI. The PESI is like history and vitals. You can see it here. History, risk factors, you know, the vitals. So you do the history and vitals. So this is the PESI classification. Then for signs of right ventricular dysfunction on an imaging test. So basically it means echo ultrasound. And then cardiac laboratory biomarkers. So it basically means troponin I. So just know that check for shock. Are we in the obstructive shock or not? Check for the history and vitals, okay? And then echo ultrasound troponin I is basically what I put here. CTPA, echo, D-dimers, troponin I. Yeah, that's how you do the risk stratification. You see that the red one is the massive, the high risk. You go straight to thrombolysis or embolectomy when contraindicated, plus supportive therapy. Always do your supportive therapy, A, B, C, D, supportive therapy, and then you do thrombolysis, okay? This is your shock, your massive one, your very dangerous one. You cannot wait. While everything else, anticoagulant and wait, okay? Very simple. This is classification of pulmonary embolism. Now let's go into details. So that was the first one. Everything is positive. Start with a general treatment. It means 45 degrees sitting position, oxygen, intubation, 3 liters per minute. Analgesia, don't be scared, go to morphine, okay? Give the strongest one. And IV fluids, vasopressors for low blood pressure. But it's an obstructive shock, and I think obstructive shock is worse on fluid administration. So yeah, I had this on my notes, but now I'm double guessing it. Yeah, here he had obstructive shock. And what do you do? This is from Professor Linhart's lecture. So massive or high risk or unstable shock. So that's the first category. Go to thrombolysis or embolectomy plus support. Exactly what Linhart said. So shock state, severe hypotension, okay. If it's good cardiac condition and he survives, then he ends up unstable hemodynamics. Start with the general treatment. Artificial ventilation is this box over here. That's what we do first, ABCDs. Usually they are in ICU and we can do an echo ultrasound, check the D-dimers, exclude aortic dissection. If it's positive on echo ultrasound, no need for CTPA, just and high troponins, then that's it, it's high. Start the thrombolysis or embolectomy if thrombolysis is contraindicated. Now for shock treatment, also it's obstructive shock, right? So obstructive shock, we have to remove the obstruction. So thrombolysis, embolectomy. So basically the treatment is removing this embolus and the shock will go away. But try to do maybe, I don't know, vasopressor fluids. I don't know, ask your professors about this. And then after the thrombolysis, we go to secondary prophylaxis, okay? Anticoagulation. So don't just give thrombolysis and that's it. You need to do secondary prevention, okay? And this is for everything. I will show you a summary in the end, so it's easier to understand. We're just going through the classifications. Now for intermediate risk or submassive, go to your anticoagulation. No need to rush, no need to activate thrombolysis, okay? Go to anticoagulation and let it do its job. Again, then, secondary prophylaxis. So always secondary prophylaxis, don't forget it. That's your warfarin for 3 to 6 months, low molecular weight heparin, breach, and stuff like that. The difference between high risk and low risk is basically they are both stable, they are not in shock. So the only one who is unstable is the massive. Only this one is unstable, like shock, okay? Everyone else is not in shock, they're stable. Yeah, so tachycardia, mild hypotension, so not in shock, but just mild hypotension. Send to the ICU, do the CTPA, check positive echo ultrasound, high troponin. You see both positive, but not shock. This is negative. Give your low molecular weight heparin because it's instant action, and monitor it with anti-XA every 3 hours, and also the general treatment as well. Now for low risk intermediate, you see that blood pressure is okay. Only one or none is positive. So for these things, for the tests, and then if you have high suspicion, you can go on and do your CTPA and your anticoagulation. You don't lose something, and you can save the patient. But if you have low suspicion, do the D-dimers. No need for CTPA. Do your arterial blood gas, do your X-ray, and if it's positive, then we can go to do CTPA and start the treatment. Okay, so this is the point. Why do we split intermediate into two? Because this one we just go to treatment, while this one depends on suspicion. And then the last one is your low risk. So nothing on the shock, nothing on the symptoms. You should decide if you assess or not. So you do D-dimers. If they're positive, goes to CTPA. If the CTPA is positive, then start your treatment. So pretty easy, pretty straightforward. Always do your general treatment. And then for chronic, I told you to read the chronic thromboembolic pulmonary hypertension. He explained it worsening of dyspnea over time. That's what he explained it, but you should study this in detail. The treatment is endarterectomy for the chronic one. So yeah, back to this diagram. We already explained it. Pulmonary embolism, yes. Is it low suspicion? Yeah, it's very low suspicion. We do D-dimers, okay. If it's positive, we cannot confirm, go to CTPA. If it's positive, it's confirmed. If it's negative, it's excluded. If the D-dimers are negative, excluded. Yeah, that's it. Basically, this diagram covers both. If you know this diagram, you can draw it in 3 seconds, explain everything, the logic. And that's the summary for pulmonary embolism. Any questions here? Okay. Always start with a general treatment, don't forget, and always end with secondary prophylaxis. It doesn't matter the severity. Always start with general treatment and always end with secondary prophylaxis. We have the massive. We look at these 3 things. If it's echo positive, blah, blah, blah. You start thrombolysis or embolectomy, depends. Then you go to low molecular weight heparin. You monitor with anti-XA every 3 hours. Intermediate, and then low risk and chronic. So that's the summary. If you write this in your exam and you start to explain it, I think that's the best classification ever. And this is my summary, like how I drew it. This is for diagnosis and this is for treatment. So I will do like a CTPA or echo, maybe D-dimers. If it's unstable, I will go with the CTPA. But if it's too unstable, then just do the echo. Unstable means massive PE, right? It's only massive high risk. Go to thrombolysis and then follow it up with low molecular weight heparin. If they're stable, most likely they're submassive or something else. So stable means the blood pressure is more than 90, the systolic. So then if I have low suspicion, I'll go with my D-dimers, do my ABG, do my chest X-ray. If they're positive, go to my CTPA. But if I have high suspicion, just go straight to CTPA. Maybe start with treatment already, give my low molecular weight heparin already. So that's like what I would do, how I would approach this. And this is a treatment. So the general, you know the general. Then if it's massive or shock, you go to thrombolysis before going to low molecular weight heparin. Unless it's contraindicated, you go to embolectomy and then the shock treatment. So you treat the shock basically, but the shock treatment is obstructive. So if you give thrombolysis, you are treating the obstructive shock, the cause. So this is an extra step when going from the massive, okay? Go thrombolysis before your anticoagulation. If it's intermediate or low, you go straight to anticoagulation. That's it. And everything ends in secondary prophylaxis and everything starts with general treatment. So it's just this extra step in massive shock. Another thing is the inferior vena cava filter if it's contraindicated to anticoagulation. So if you cannot go here, then go to inferior vena cava and then go to mechanical secondary prophylaxis. So I think this is basically the logic. I hope you understand the logic behind it. And this is the chronic thromboembolic pulmonary hypertension. And yeah, you should study a bit about it, about chronic microthrombi unresolved over time. And pulmonary endarterectomy is like a surgical procedure for cardiovascular procedure. Reminder, in real life, you do ABCDE, okay, stabilize them, do the diagnosis, and do the permanent treatment. And you can leave a feedback. I'll give you a certificate if you go to my website for attending this session. Do you have any questions? Are you okay? Did you get the logic behind it? Is the logic clear now?
Yes. Just one question. You said that if you have the patient with, let's say, pulmonary embolism symptoms, and he has positive D-dimer and also, let's say, also what is that? Echocardiography is positive, you don't have to do CT. You could just give him thrombolysis if it's massive, right?
Yes. So echo ultrasound is in conjunction with the troponins and whatever, like the D-dimers, they give you a very, very high suspicion. So you don't have to do the CTPA, but if because it's shock, like so just treat the patient. You can do CTPA afterwards. I don't know, but the guidelines, it's exactly how Linhart had it, because this is from Professor Linhart. He had it like this, and he said always do thrombolysis, So he didn't care of like the order. He wanted for the exam. We're talking not in real life, right? In real life, you're gonna be trained. I don't think you will be alone doing pulmonary embolism. So he wanted to differentiate that all of this is anticoagulation, which you just stop the formation of new thrombus, like propagation of this thrombus, and you let it by itself dissolve slowly. While if it's the shock, that's why he highlighted shock. He circled it. It's like shock, obstructive shock. You go to thrombolysis. So this is the most important. If you go to the exam and you show your knowledge that you know the classification, you know that the shock is basically thrombolysis while everything else is just slowly anticoagulation. And you also say about the cardiac troponin I, you say about D-dimers that is also for aortic dissection, if you go and explain your logic, no one will fail you. Like you will not fail. I don't know how helpful it is for clinical practice. I didn't work with pulmonary embolism in real life, but the point is the exam, passing this exam. You're medical students, 6th-year medical students, just show that you understand the logic. You understand that pulmonary embolism can be not just thrombus, it can be everything else like amniotic fluid or whatever. Okay, you know this one. Most common is DVT and thrombus. Okay, so that's why we treat with anticoagulation. except if it's too massive, we don't have time for anticoagulation, just use something faster, use alteplase, and do thrombolysis. If contraindicated, know your second line. My second line is embolectomy. When I use my catheter, go there, remove it. So you show your logic, and if the doctor sees that you know this logic, he will just say, okay, next question. Like, it's just if you want to do internal like me, like all of these things is because I wanted to do internal, so I wanted to have good notes and I wanted to understand it completely. That's why I did these summaries.
Okay, thank you, man. Yeah. Important
for gynecology is don't do VQ scintigraphy, okay? Use the CTPA for pregnancy. The CT radiation is less than the VQ scintigraphy for the baby. So yeah, like this is for gyne. Everything else is the same for surgery, same for internal. No negative predictive value only. You see, the positive is not highlighted. If it's positive, we just go to specific test, positive specific test. Only if negative is excluded. And the only specific test which is negative exclusion is CTPA. Did you just want to pass? Thank you. Say, yeah, no, just pass it. So, yeah, go there, have a logic, show that you know something from the history, something from the physical exam, something from the imaging, know a bit about how does the thrombus look on X-ray, how does the thrombus look on ultrasound, is it hyperechoic or hypoechoic, does it depend on time, if it's like a new coagulation, old coagulation, you know, like try to show your logic. And I think you'll be fine. I think this is, I mean, this is super detailed or like super well explained because you saw how many questions, how many times it appears on this pulmonary embolism. There's so many state exam questions. You can grab a pulmonary embolism discussion about shocks, about So
what you did for us is not just for internal medicine, but for like these other subjects.
Yeah, so this is why you should know it very well, and yeah. It appears 2 times also in internal medicine. Emergency pneumology is also one. The coagulation treatment, we discussed it. Low molecular weight heparin, DOACs. And everything with pain, remember, pain, history of pain. Okay. If you don't have any questions, then we're going to stop.
Yep. Okay. Thank you then. Yeah.
Thank you. Okay. So before you leave,